We've talked this morning about clinical transformation and how clinical leadership is needed to drive changes in the delivery of care. We've talked about matching that up with changes in payment reform. Rich's presentation was a nice way of putting some of those ideas together from the standpoint of CMS. Come on up. What we're going to do now is take another step in terms of opportunities for clinical leadership, and that's clinical leadership in the direction of community-based reform. So why stop just with reforming healthcare organizations, healthcare delivery, and healthcare payment when there are so many other opportunities outside of traditional healthcare to drive improvements in reform? And this is probably particularly important for patients in the community who may not have that good of ties to the healthcare system or may have opportunities while they're out in the community to get better support for staying healthy and managing their problems. And that's going to lead us to a lot of discussion of vulnerable populations as well. Now, this format for this session is going to be a little bit different than what we've had so far. We're going to start off with a presentation from Jeff Brenner, who many of you may know. He's a family physician from Camden, New Jersey, who served as the executive director of the Camden Coalition of Healthcare Providers since 2003. Camden Coalition is nationally recognized for its accomplishments in these areas of community-based delivery reforms for some particularly challenging populations. The work that Jeff and his colleagues have done has been highlighted by Atul Gawande and others. Jeff is going to talk about their experiences, their challenges, and what they see as the biggest opportunities for clinical leadership, meaningful clinical leadership going forward. And again, fit nicely with, I think, what you've just heard. Then, after that presentation, we're going to have a discussion that will also involve Barbara Tobias and Ellie Yost. Barbara is also a family physician. She's the Robert and Mafani Smith, I got that right? Chair of Family Medicine at the University of Cincinnati College of Medicine, the medical director for the Health Collaborative of Greater Cincinnati. That's a community-based organization whose mission is to employ collaborative leadership in identifying issues, developing programs, measuring outcomes, and reporting with the explicit goal of improving the health of the population of Greater Cincinnati. So a very community-focused effort. And she's going to talk about clinical leadership for multi-stakeholder, community-based collaborative effort like that. And then Ellie is a nurse, director of nursing for the Nurse Family Partnership. That's an organization that helps communities leverage resources, including nurses, to address the needs of vulnerable first-time mothers. She's going to talk about her experience in these community efforts to improve pregnancy outcomes, child health, and development of economically self-sufficient families, again, going kind of beyond the traditional scope and goals of healthcare and very much needing clinical leadership. So with that, I'm going to turn this over to Jeff. Do you want to come up here for this or whatever's easiest? Okay, thank you. Please. Oh, and if you come up here, you got to disconnect.
Great, thank you so much. It's nice to be here today. Carrie, thank you for the invitation, and Mark as well. I want to talk about the work that I've been doing in Camden and reflect a little bit on some of the things I've learned about leadership there, and talk a little bit about where I see some of the path forward for the kind of work I do and the characteristics that we need in leaders. It feels to me like we're at an inflection point in our country and our healthcare delivery system, and that there is really a profound leadership crisis. And as I look at the leadership crisis in healthcare, it looks to me a lot like the leadership crisis we've had in our financial industry, in our political system, and in other parts of our country as well. In healthcare, we have, I believe deeply in symbols, and I think in healthcare, the symbol of leadership has really been the physician scientist or the physician technician. And we have rewarded physician scientists and physician technicians. We have used a lot of NIH money. We have, through our CMS RVU fee schedule, we have really elevated our physician technicians and scientists to a great extent. And that system has succeeded. Since World War II, we have built an unbelievably skilled and complex delivery system that really does amazing things. But I think we've exhausted that leadership model, and as all of you know, we've created a system that's unaffordable. We misapply our wonderful technology on a daily basis. It's become a reductionist system that's not organized and not holistic. And as I look forward, I really feel like the fixes to this are really, it's not a technical problem. As someone said earlier about adaptive leadership, that the failures in our delivery system are not so much technical problems as really leadership problems. And when I say leadership, I mean that they're a problem with our values, a problem with our, that it's a moral problem, and it's probably not a problem that purely insiders can fix. I think today we are insiders at the Brookings Institute talking about the delivery system, but that at some point, probably baby boomers, the 85 million baby boomers that are headed like a freight train to the delivery system that's ill-equipped to deal with them and deliver organized care are going to have to stand up and say they've had enough, and that it's probably not it's not possible to change 18% of the economy purely through an insider strategy, and I'll talk a little bit about that today. I want to talk a little bit about the Camden, the city of Camden, and the work that we're doing. I'm a family doctor. I've spent most of my career for the last 12 years as a frontline primary care provider, a family doc. I graduated my residency in Seattle and moved from downtown Seattle to downtown Camden. And if any of you have visited Camden, you might know it's really one of the poorest cities in the country, first, second, or third poorest, first, second, or third most dangerous city. 3 of our last 6 mayors have been indicted and convicted of corruption. We've been in various levels of state takeover for many, many years. It's a very complex place to work and to live. I lived there for about 8 years as well. And you get to see the very naked exercise of power in a democracy and sort of the inappropriate use of power in a place like Camden. You get to see what the impact of bad leadership is on people's lives. And you get to see the connection between sort of almost a lack of values and a lack of morals at the leadership level and how that plays out in people's lives. And certainly as a clinician, you get to know people really well. I speak Spanish, so I was working in a 3-exam room office, running from room to room, seeing kids, adults, delivering babies. I did OB for about 10 years and carried my own cell phone, was on call for my own practice. I really retreated from the medical world. I really felt like Camden was going to I was going to make a bubble, and I really felt like, as I was in training, that there's a lot of unethical things going on in healthcare, and that being in a small 3-exam room office was my ideal place to be, that I could really unplug and disconnect from all of the things I saw in the delivery system that I felt like were unethical, and create this sort of idealized medical office. So we were paperless, we had all electronic health records, we did group visits, we did open access scheduling. I felt like for Medicaid patients that we were breaking new ground. I used to kind of lay awake at night and imagining, how would I ever get to 100% on everything, like mammogram rates and hemoglobin A1C? What it would take? Like, how would you have to just break the system apart and reinvent it? The problem is that my sort of little bubble in my office really burst by the fact that New Jersey's Medicaid rates are some of the lowest in the country, and they got worse and worse. And I knew how to make capitation work, and many of my Medicaid HMOs started switching me back to fee-for-service, and I couldn't make that model work with the style of care. So my office went under, and when offices in Camden go under, they just get boarded up. So my office is empty at this point. And that was sort of a profound humbling for me, and sort of my idea that I could make a bubble and sort of hide in there and kind of reinvent healthcare in my little office, that wasn't really going to work. So somewhere in all of this, got very interested in getting to know my other colleagues in small offices. There are still small offices in Camden. They're sort of rapidly going away, but put together something called the Health Provider Breakfast Group, which is literally a bunch of small solo practice practitioners in Camden hanging out having breakfast. We did that for about 3 years, and we do what doctors do when you get them together. They complain a lot, and really felt like we had a lot of shared problems. And it's because we weren't going to the hospital anymore seeing our patients that this was really the venue for us to get together and share things. And it wasn't just physicians. This was nurse practitioners. There are a lot of nurse practitioners in the city of Camden, and PAs as well, delivering care in underserved communities. We eventually incorporated. We invited the hospitals onto our board. We tweaked the voting power because we were concerned they were going to take over. We invited the federally qualified health centers onto our board. Now we have social service providers, behavioral health providers, and I'm proud to say we have 2 community residents on the board as well, which has been a really interesting experience. We run a portfolio of different projects that are broadly aimed at improving quality and reducing cost. And my goal in Camden is for Camden to be one of the first cities in the country that's also one of the poor cities in the country to bend the cost curve, because I really feel like in the moral and ethical vacuum of healthcare that it would say something really important. If a place as poor as Camden could pull this off, it would really say something to the rest of the delivery system, that it's not a technical problem, that it's an adaptive problem, that it's a values problem and a moral problem. So I think we're on the way to that. I think it's still a very complex challenge. To give you an idea of some of the projects that we're operating, the first thing we did was put together a claims database, which was an MD-MPH student project, and it was initially focused on accidents and injuries, and we managed over the course of 3 years to get all of the raw claims data from all 3 hospitals. And I'm sure many of you know this is business intelligence to the hospitals. They don't want to let this out. We got the name, address, date of birth, date of admissions, all the ICD-9 codes, charges, receipts, had no idea what we were doing, put it in Excel, that didn't work, in Access. It, believe it or not, it still lives on 2 hard drives locked in a metal box that's encrypted, password protected. We use Microsoft Access, some very inexpensive linkage software to link claims across the hospitals, and ArcView to map all this. So it's about a $10,000 operation every year. I use a very smart 23-year-old to make lots of cool maps, graphs, and charts. So that's an all-payer database, right? That's the holy grail of data that we all want. So it's been really powerful to build strategies around. And one of the strategies, it was an incredible database for me to look at because my patients were in the database. And as my office, I'm making payroll every 2 weeks, and I'm having to draw down a line of credit, and I can't keep this thing going. And I'm looking in the database, figuring out where all the money's going. And the money wasn't obviously not going to my office. As offices like mine are getting boarded up, the emergency rooms tripled in size in Camden, and the hospitals built new wings, massive expansions in the inpatient and acute care settings. And as I'm looking at the data, I'm seeing my patients going to the emergency room getting, the hospitals are getting payments of $150, $300, $500, $800, $1,000 for ER visits. And just realizing how distorted the marketplace of healthcare. I came across the Dartmouth Atlas at one point, and the Dartmouth Atlas really spoke to me in Camden, which was that in the marketplace of healthcare, when we set a really high price for a certain set of services, we start to get too much of that at some point. And if we set a really low set of prices for my services in primary care, well, we won't get enough of that, and we'll begin to distort the marketplace, and that feels like what we've done in Camden. If a patient needs a kidney transplant in Camden, I can get them evaluated immediately. If they need a basic appointment to control their blood pressure and control their diabetes, we could wait for weeks to months. And I think the way that you all should look at Camden, you know, in a poor community like Camden, we get to see all the stuff way before the rest of the country. Like foreclosure crisis, we've been there, done that. We had that 20 years ago. Primary care crisis, been there, done that, you know. And I can tell you what happens in a primary care crisis. It's really ugly. Our number one reason to go to the emergency room in Camden are head colds, 12,000 visits for head colds over a 5-year period. Number 2 is ear infection. Number 3, sore throat. Number 4, viral infection. Number 5, stomach virus. It's all primary care stuff. The vast majority of those patients are insured patients. These are poor moms and kids sitting with their kids crying in the emergency room for 6 hours. They call and they can't get appointments. And I hear lots and lots of people say, well, poor people like to sit in the emergency room. Trust me, they don't like to sit in the emergency room. High utilizers, they like to sit in the emergency room because their choice is either to be homeless or to sit in the emergency room. But poor moms and kids, if they had a better choice, they would take it. If they felt like they could call a phone number and the person on the other end of the phone knew them, was polite to them, maybe spoke in their language, they would probably call the number. If they felt like they could get appointments, they probably would go ahead and call and get those appointments. The other projects that we're running, we've had a team, an outreach team, tracking down high-cost complex patients for the last couple of years, and it's really been a root cause analysis. High utilizers are an incredible opportunity to find out what's broken in the delivery system. Each one of them are such a rich, contextual, complex story, and they have touched every institution in the city. So we have worked through 1 case, then 2 cases, then 5, then 6, then 10 patients, 1 patient at a time, and it turns out that it's a really good way of bridging public health and clinical medicine, that you can get clinicians to think up on the balcony in a much broader systems way by doing it in case-based learning and doing it 1 high utilizer at a time. And those high utilizers really begin to challenge us as a system to rethink our basic assumptions, and I think that's been the greatest value locally in this. It's also built a lot of relationships between entities in ways that I wouldn't have imagined before. The second major project is a classic medical home collaborative. We're using diabetes as the lens, but it's really transformative work in primary care offices. As anyone doing this work knows, this is hard, messy work. It's very challenging, particularly in an environment with Medicaid rates and offices that are struggling to stay open. We've had great luck using AmeriCorps volunteers. They're my favorite part of the work we're doing. These are really smart 22-year-old kids who are very enthusiastic, have a lot of energy, and they turn out to be great practice change specialists. They're really good at helping practices implement electronic health records and do quality improvement projects, pull charts, make registries. They make great patient navigators. A lot of the things that the delivery system needs, we don't need, super high training that a really smart kid out of college can do very well. I'm proud to say that a lot of them are now going on to med school and nursing school, and I really feel like what I'll get back to in a couple minutes is that if we want to create new leaders in medicine, I think we're going to have to do it before they get to med school. That med school is a very damaging experience, as is residency. And then the last major piece of our work has been to build an HIE. So we have a working HIE in Camden. It's got real-time labs, radiology, and hospital discharge summaries streaming into a data warehouse from now 4 hospitals. We have legal access and technical access to all the underlying data so that we can build registries, and we can also do real-time alerts. So my goal we're almost to this in the next week or two, someone mentioned this earlier, I want to make sure that every provider has a list every day of who's currently in the hospital and who's been in the emergency room. That's going to drive everything. And I want to make sure that list has how many times they've been in the ER over the last year, how many times they've been admitted, and how many times they have been to primary care offices. And also aggregate stats for their practice at the practice level. The last and final thing we've done is to figure out a business model. I go up to the state of New Jersey and they say, it's great what you're doing, you're kind of a one-off pilot, it's not replicable, we can't fix Medicaid around you. So we finally got fed up with that, and we made friends with folks at the New Jersey Chamber of Commerce who hired a lobbyist to help us fix this. And watching all of the work that the Brookings has been doing and Dartmouth's been doing around ACOs, really felt like we could take this ACO model and kind of tweak it to make it more community-based. That my big fear is that a hospital-centric ACO is just going to be giving more money to the same system. And the underpinnings of the model are that the average patient is loyal to the average doctor, is loyal to the average hospital. And that's true for the average patient, but all the costs are driven by outliers. So, and the problem is the outliers are highly mobile, particularly in an underserved community. So our data, we have data from Camden, Trenton, and Newark showing that the top 1%, 80% of them go from hospital to hospital, ER to ER. So they're incredibly mobile, and the last thing we need in Camden is a Cooper ACO competing against the Lourdes ACO, competing against a Virtue ACO, fighting over poor people. That will work in the suburbs. It won't work in an underserved community. And not only that, but I don't think that the hospitals want to have my patients in Camden in their denominator. So it's really a win-win, was to carve the city of Camden out and say, let's do a different model here that's a collaborative model instead of a competitive model. So we wrote legislation and we got it passed. It's a very painful process running around New Jersey for 2 years to do this, but our Republican legislature, both Democrats and Republicans in the legislature supported it, broad bipartisan support, and our Republican governor signed it as well. So it's law, and we're in the middle of adopting regulations and kind of getting ready for this. So I want to talk a little bit about some of the lessons I've learned about leadership in doing this work. I mean, it's a very intense level of collaboration locally that we've generated, and talk about some of the current deficits in our leadership model, and talk about how we're trying to either address this or how we found this within the coalition. Many people have talked already about within the healthcare system that we've got a very hierarchical model with clinicians at the center. And, I had this own problem myself in my office. I felt like I was going to, be at the center of this office and do really good care, and I didn't build a team. I was doing my own accounting, for instance, and I should have hired a bookkeeper. I needed a team to help me run this office. So in the coalition now, I've got a management team that's really an outstanding group of people, all of whom are not clinicians, actually. I'm the only clinician in this 5-person management team, and I sleep much better at night now, not feeling like the weight of figuring this out is on my shoulders, and also recognizing that I have incredible deficits. There's nothing about running from room to room to room for 12 years in a Medicaid office that in any way makes me good at running now a 25-person organization, that I really needed a management team and sort of letting go of control. So that was a personal lesson. The other thing that we've really wrestled with a lot is that every project that I'm running where I've got a really talented 23, 24-year-old program assistant or project manager at the center of, and then I have a clinician that's just along for the ride, those projects run great. Every project where I've got a clinician who sort of thinks they know more than they really know, and they want to insert themselves in the project management decisions, those projects are a complete mess. And it took us a long time to figure that out. And now we've done something around decision-making rights. And there's some really good writing about decision-making rights and really dividing out what's a clinical decision from what's a project management decision. And I think 80 to 90% of this stuff is actually project management, not clinical decisions. And most of the clinical decisions should be protocolized and standardized. So that's a pretty big realization. So I need my clinical directors or my clinicians who are cost me way too much money and I can't afford them to stop running around holding meetings and project managing and getting into stuff they don't need to get into and just stick to helping me protocolize and standardize and then let our project managers do the project management. And as we've gotten deeper, we talk about this all the time now. Is this a clinical decision or project management decision? And really constraining the role of the clinicians. I never thought my job in this coalition was to be constraining the role of clinicians and that their leadership role was going to be a more constrained role, not a more expansive role. And that what I really needed were a whole new generation of project managers that were generalists who could manage clinicians. And our organization now looks like a consulting firm. And as I look around the country at people really doing this work, we all have to grow this new cadre of people that can have the confidence to stand up to clinicians and to project manage. And that all of the problems that we're having are like Henry Ford problems of figuring out how to standardize and protocolize so that we can customize and individualize. And that's a project management problem. The other thing that we've learned about this sort of hierarchical model decision-making is our board makes decisions by consensus, which is a lot of work. So for 9 years now, we've made all our decisions by consensus. And the most controversial one was we recently signed a contract with United Healthcare. They're our second largest Medicaid payer. That's a shared savings contract, so it follows the structure of the legislation. And I needed to get the vote of every board member. And some of my hospitals are nervous about going from our kind of cute, kind of scaled, or cute little projects that are getting lots of attention to like, now the numbers are getting bigger and maybe we'll scale and what's this going to do to our dish payments and our GME and all this sorts of stuff. So, but I really felt like I couldn't go forward in this until I had consensus. So, really the need for thinking about consensus-based decision-making. The other thing I've learned, which is really an interesting learning point, was the absolute lack of compassion and empathy amongst many of my peers. As I've talked more and more about the High Utilizer project, it has had generated really intense reactions from some clinicians. And I'll have clinicians come up to me and they're almost shaking. They're like, if those high utilizers would just do what I told them to do, they'd all be fine. And, all these words about compliance, and we've seen our patients yelled at a lot in the delivery system. And it took me a long time to think, like, these are really pitiful people. I mean, they're struggling with unbelievable challenges. I mean, no one wants to go 115 times to the emergency room. And in Trenton, we found someone that went 450 times in 1 year. I mean, these are really damaged, traumatized people. So, why in the world would someone making $200,000-300,000 a year, living in a nice suburb, get so angry at these patients? Like what, I finally realized it wasn't the patients, it was something about them. And really thinking about what's going on amongst my colleagues, that this model of the physician technician and the physician scientist as leader has in many ways really damaged us because it's truncated our empathy for patients. And we've begun to take physicians out with our team so they get to see what's going on in the community, and that home visits are a great way of sort of breaking down some of these barriers. And, and we talk a lot about adaptive leadership. We're beginning to talk about that internally, and I think there's going to be a huge hearts and minds change that my clinician colleagues are going to need to go through, of throwing the word compliance out, of really rethinking what drives patient care, what drives change, and how nonlinear people are. And I think we're going to have to elevate a new model of leadership. Another learning point I've had in all this was part of my role in the last 10 years has been to be an advisor for a student-run clinic, and it's actually a pretty complex organization. They do a whole lot of patient education activities, but student-run clinic's really interesting. It's about 50 students, they're all third-year students, and they pick up 2 to 3 patients each, and they're responsible for caring for that patient soup to nuts. And the med school actually excuses them from whatever they're doing to go and scrub in, to go to the Board of Social Services, to go to the mammogram appointment, whatever the patient has going on. They've adopted electronic health records. We have clinicians that come in precept. And the patients get very, very attached. The students take call for their own patients. And they have a whole leadership structure to run this, and it's really interesting to walk into the office and watch what's going on, because they start yelling at each other, they get mad at each other, the flow gets backed up, and they're saying, why is it getting so backed up? You're so slow, or this is going on. I mean, they fight for all the same reasons that we fight. They have to develop a budget. They have a generic formula, and they order medications, and they have to count the pills out. And what we've learned over time is that we used to have one person in each of the leadership spots within the organization, but inevitably we had lots of bad leaders, and that it would kind of mess up the organization. And all of the leadership turns over every year in the organization. So we began to pair them up and have two leaders. And what we've seen in 10 years of doing this is that the quiet, reluctant leaders have, by and large, always been the best. They are mission-directed, and the loud, somewhat narcissistic, and somewhat immature students who've sometimes come directly through school and they've always done really well in everything they've ever touched, but all the problems they've touched have been highly structured problems. It's a test, it's a paper, and they get to the unstructured world full of people and full of messy stuff and nonlinear thinking, and they just can't handle it. And they try and overbear it, they try and control it, and it doesn't work. And they tend to be a lot more men than women. So a lot of our best leaders in this student-run clinic have been women, and they have not viewed themselves as traditional leaders. They wouldn't see themselves on the track to be a chief or to be a CEO, but they've all been the best leaders. And that's been a sort of pretty profound realization on our part over time. So the last thing we've learned is how important dissenting voices are, particularly when you're engaging in such hard work. Our work is totally unstructured work. It's not like I open a book, as someone said earlier, and say, how do you transform care in one of the poorest cities in the country? That we really have to make this up as we go, and that dissenting voices and uncomfortable discussions are very, very important. And one of the ways we've fostered that is by getting into high-cost buildings and meeting high-cost patients. So we went to the most expensive building in the city and teamed up with a church group that's called Camden Churches Organized for People. They are an old-school community organizing group that fight for better, safer schools, safer streets, and one of their main pastors' church is right next to this high-cost building. And we pulled residents in the building together, and I showed them all our data and said, do you feel like you got $12 million worth of care in the last 5 years? And they were appalled that anyone made that much money on such bad care. And there's a major academic health center only 5 blocks away. And essentially, good doctors and good hospitals are going to work every day delivering this really unpatient-centered and fragmented model. And we're just eliciting these crazy stories from patients and videotaping them and eventually assembling this group into a leadership team. We've taken them to CMS. We've taken them to Trenton. They helped to lobby for the legislation. We've had state officials come into the building. And then we had a retreat at a church. And it was really to make a covenant that we were going to promise one another to start behaving differently, that we were going to embrace a new clinical model, a new leadership model, and have some hard discussions. And we went through all the data. My hospital CEO was there. We had state officials there. We had Medicaid HMO leaders there. We had patients, physicians, and eventually came to the conclusion, and sort of promised one another that we all have to wake up in the morning and do something different, and that if we keep doing the same thing, it's not going to work. We literally hung the covenant on the wall, and everyone signed it. And we made 2 concrete promises. One was to listen to the residents in the building and follow their leadership. And the other was to support the shared savings legislation, which everyone in the end did. The outcome of the work in the building was about 12 weeks ago, one of my board members, using our claims data, was able to build a business model for opening a clinic there. So we've opened a very small office in this very high-cost building. That's no grant money. It's privately funded. And it's sort of a great experiment. My goal is to throw everything in the kitchen sink at this one building to see if I can bend the cost curve. So we've got a diabetic support group in there, a yoga class, now this clinic, and we're just going to throw lots more stuff in there. We're going to do the same thing with our high-cost patients, throw everything in the kitchen sink and see if we can, 1 patient, 5 patients, 10, 100. And then the same thing with single primary care offices. We've spent a lot of time trying to figure out what it's going to take to bend the cost curve in a single office. So I want to close up with just 2 final conclusions and not spend too much time on this. I'm sure many of you have heard of the model of servant leadership, which is really the model that has most influenced me. And just close with a quote. Robert Greenleaf was the thinker behind this model, and he worked in AT&T back when it was Bell Telephone, and really thought a lot about who the best leaders were at AT&T. And around the same time in the 70s was watching all these failures at a national level. Vietnam, watching Watergate, really feeling like there was a leadership vacuum. And what he said is that a servant leader is servant first. Becoming a servant leader begins with the natural feeling that one wants to serve first. Then the conscious choice brings one to aspire to lead. And the person is sharply different from one who is leader first. The difference manifests itself in the care taken by the servant, first to make sure that other people's highest priority needs are being served. And my goal in leading the coalition is to make myself obsolete, and it's to make my staff one day take over the organization. And he goes on to say the best test and difficult to administer is, do those served grow as persons? Do they, while being served, become healthier, wiser, freer, more autonomous, more likely to become servants? And what's the effect on the least privileged in society? And will they benefit or at least not be further deprived? So that's been my touchstone as I've done our work in Camden. And I think that translates easily within a healthcare setting, and we could use a lot more servant leadership in healthcare. So thank you very much.
Jeff, thanks very much for a great perspective and recounting your experience. So I'd like to turn now to our other panelists, Barbara and then Ellie, for some initial comments on this general theme of physician leadership at the community level, and then we're going to open it up to more discussion.
Great. Well, I'd like to thank Brookings Institution for being here. It is such a privilege to be here with clinical and thought leaders. And I'm really grateful for this experience. And I'd also like to thank Jeff. You know, the article, Hot Spotters, I think was not only got national recognition and others to join the conversation, but it gave us as physicians talking points. And we had several discussions around Camden, New Jersey. And, you know, I think most of us said, duh, we know this. As clinicians, we know your patients. And it was terrific to have voice to that. You know, I think we're talking about changing culture. And I would argue that if I had all of your, you know, for the physicians in the audience, if I had all of your personal statements that you wrote to apply to medical school, and as someone who's been on admissions boards for years, I've read many of them, I would argue that what you talked about in your personal statement is exactly what you're talking about, servant leadership. But as you know, we get the stuffing knocked out of us. I think, though, that change is happening now. In answer to Jeff or to Kevin Schulman's point, why change now? It's happening now because we're returning to those values that are already internal. All of the things that we're talking about, the CMI initiatives, patient-centered activities, ACOs, accountability, responsibility, not letting patients drop through the cracks with transitions in care, that's something we know as clinicians has to happen. And when we are put into settings, residencies and our professional settings, the stuffing gets knocked out of us because obviously the incentives aren't aligned. So change is going to happen now because it's hearkening back to something that we know is true to patient-centered care. It's the right thing to do. So it's not new learned behavior. I want to just hit a quick bright spot in AF4Q lingo that's happening in Cincinnati. We have a multi-stakeholder collaborative by design. So we have payers, providers, plans, consumers, patients, all sitting at the table. And we have a public reporting site, Your Health Matters, and we have over 450 primary care docs voluntarily reporting their clinical outcomes data. It's not claims data. They're going into their medical records and they're reporting performance goals around diabetes, intervascular disease, and they will soon be reporting cancer screening rates, CHF. Patient experience will be on this, as well as hospital data. Physicians and learners are motivated by data, as we've all heard. There is also the all of the cycle of grief and everything goes when you first see your data. It's just as if someone died. There's denial, there's anger, there's bargaining. But when you have a trusted source, when you have a community collaborative presenting your data, not a payer, not a plan, and you have physicians guiding what measures are going to be reported, then you start to have trust. And that's what we're seeing in Cincinnati. The difference between this, a physician portal, and some of the other things that are out there is this is for the patients. So on Your Health Matters, we have content specifically for consumers and patients to help them in their decision making. And I think we have to start acknowledging the role that our patients have in their decisions, and not that they should take over the role of physicians. We don't want to just provide them data and have them in charge of their own health care. We really have to empower them with tools. So these are some of the tools that are happening now that I'm very proud of. I think we can talk more of that. I also want to talk a little bit about paying it forward. What we can do as clinician leaders is mentor. And the question was asked earlier, what's the one thing you could change right now to foster more leadership? Mentor. Mentor students, mentor pre-med students, bring them to your offices, include them in these meetings, and show them why this is an exciting time to be in healthcare. So with that, I'd like to kind of just end with one thought from one of my colleagues who's a physician leader who's just been tapped to be the physician in charge of transformation for a large healthcare system. The leadership does not include physicians at the very top. And she was saying that they've decided they're going to be an ACO, and they want to just sort of snap their fingers and make it happen. She said she's sort of going between the sky is falling and the emperor has no clothes. We have to involve physicians in every step of the way to create accountability and responsibility and buy-in.
Thanks very much. Ellie?
Thank you very much for being here. Thank you, doctors. It's an honor. I feel like the sole nurse, although I know I'm not, but I'm going to talk a little bit about nursing leadership, and nurses need to be at the table also. Right now, nurses are close to 3 million strong in the country. They're growing. Advanced practice nurses right now are about 8% of that, close to 3 million. And while what I've read is primary care physicians are not growing, advanced practice nurses are growing at about 9% a year. So as we're talking about reform, I just want to put in there that the nursing population, anything that's going to touch physicians is going to touch nurses and vice versa, and that we have to be working collaboratively. You talked a little bit about physicians and the challenges of school and what it kind of punches out of you. And unfortunately, I think nurses learn in nursing school that there's a built-in tension between physicians and nurses. Let's just put it aside. If it is, let's make it history, and let's move forward together to serve clients. And in Nurse-Family Partnership, which is in Camden, this is an evidence-based program. We have 30 years of evidence. We have 3 clinical trials. We serve the most vulnerable pregnant women. We follow them through their pregnancy until the child is 2 years old. We're in 38 states. We're in 5 countries. And we have started this year serving 3 tribal nations. And the approach in Nurse-Family Partnership is home visits every other week. To support the mom, our outcomes are that we want this mom to have improved pregnancy, a healthy pregnancy. We want this child to have improved growth and development. And very importantly, we want to see this family at the end of the 2 years have a life plan to be financially sufficient ongoing. And so I just want to read off to you some of our proven results. And these are from the clinical trials. 48% reduction in child abuse and neglect, 56% reduction in emergency room visits for accidents and poisoning, a 32% reduction in subsequent pregnancies. We don't ask moms to not get pregnant. We help them understand what close pregnancies mean to both their health and their family's economic self-sufficiency. There's a 67% reduction in behavioral and intellectual problems at the child age 6. The clinical trial started in the 70s. These are longitudinal trials or studies. We're still following the index children who are now in their 30s. Because what we want to do is see if this is a generational change, and it is. This has been proven to be a generational shift in prevention in healthcare. 59% reduction in arrests at age 15, this is of the child, and an 83% increase in labor force participation. For every dollar that's invested in Nurse-Family Partnership, there's an over $5 return to society. So what is our leadership model, I guess, if we want to talk a little bit about leadership? We embrace a reflective leadership model. We work with the nurses to make sure that when they're working with the clients, they are reflecting with the clients. They use a motivational interviewing approach to behavior and health change, meaning that nurses love to go in and tell you what to do. We love to go in and push information at you. And what we do is we bring all of the nurses together for education for a paradigm shift. That until the client wants to make the change, until the client believes it's important in her life and in her family's life, there will be no change. So we teach the nurses how to work with these very vulnerable clients to come to their own decision that they want to make this change. Funding systems. Is the Blue Cross Blue Shield gentleman still? Yes, Blue Cross Blue Shield is funding some of these implementation programs. They're being funded out of hospitals, they're being funded out of nursing schools, and then in 5 of the states, actually, it's in law that every eligible mom in that state will be offered an opportunity to enroll in nurse-family partnership. It's 100% voluntary. The client has to be referred, or she can self-refer, or someone has to refer her, but it cannot be mandated by a court or by anyone else. The mom has to enroll voluntarily. I think that's it for nurse-family partnership.
Ellie, thanks for that great perspective. I would like to open up this discussion to comments from all of you, and we'll have microphones around again. So hands up if comment or question, and maybe just to start this off. I think you all touched probably everybody in this room with connecting back to why they got into the health professions in the first place, which was to serve and to make patients' lives better. And that seems like a nice goal, but at this stage in our healthcare system, with so much at stake financially and so much potential impact on people's lives, having this focus and this leadership, this approach to leadership, generally means going along with some new kinds of accountability for things like the overall results for a patient and overall costs, and things like, Ellie, you were just talking about things like labor force participation and arrest rates. So that's a different kind of responsibility and maybe a little scary too. Mm-hmm. How's that going?
You know, I think that the way to move this forward is with data. And so just as the medical student is very quick to see whether they're above or below the mean on their test, when you have trusted, reliable data, physicians then are motivated to improve. And it has to be transparent, not just to the practice, but across systems. And there has to be agreed upon performance measures. Others talked about making sure that there's an even playing field there, that there's trust in methodology. Once you have data then, the payers can look at that too, and then they can reasonably incentivize performance and other quality indicators. You have to have physicians and other multi-stakeholders around the table to develop those. But I think that you can't move forward. You know, as a doc, of course I used to say I'm a medical home. I looked at my patients in the eye. I provided warm and fuzzy treatment. I even made extra calls that nobody knew about on the weekends too. But unless I saw my data that maybe only 7% of my diabetic patients had A1Cs below 8, I didn't believe that I wasn't really performing up to standards. So I think we have to see our performance concretely before we can move forward.
Also, to go back to a point Richard made, what does good care look like? I don't think we really know what good care looks like yet. And the wonderful thing is that we have some examples out there that are evidence-based. So I think the nurse-family partnership is, and I would encourage you to go way beyond what you heard today and read deeply about it and think about what it is. I've been very inspired by the model. We also have Ryan White clinics, which are for patients with HIV. They are a true medical home for HIV patients because of the extra subsidy and the commitment and the patient engagement and the groups like ACT UP and HIV activists. HIV patients get really good care in our country. They really get wraparound care. So that's a second model. The third model is PACE programs. If you ever get a chance to visit a PACE program, they're really an amazing model for frail elderly. The fourth model is a PACT team, which is a psychiatric hospital without walls. It's a very elite team that provide care in almost every state. It's an evidence-based model. It's the analog to the nurse-family partnership for severely mentally ill schizophrenics and other types of patients. So we have these pockets of care that I would say, I bet a lot of people talking about accountable care organizations haven't even spent time reading about, visiting, and looking at, that have been accountable care for 30 years. So, with very rich data, with standardization, with protocolization, all the kinds of things we talk about. So, so I'd like to see us do more to elevate what good care looks like. Because when the system starts falling apart over the next couple of years, we're going to need to talk to the media and say, that's what good care looks like. And when you just do across-the-board price cuts, that's what bad care looks like. And, high deductible plans, that's what bad care looks like. It results in bad care. So, we're going to need to be really pointed in talking to the media about what good care looks like.
And I want to add to that a little, to both of you. Great points about data and what care looks like. In Nurse Family Partnership, we do it twofold. So we have data constantly coming in. We look at the outcomes of our clients, but the other thing that we assess is the nurse based on her competencies, the supervisor based on her competencies, and the nurse consultant based on her competencies. Because it's one thing to see client data, and we have client satisfaction surveys coming in. Because it's one thing to see client outcomes, it's also something else to see, are the providers providing to their competency?
Comments? So up here, Barbara, go ahead if you have
a quick comment. But this is a remarkable presentation by all three of you, and very inspiring. One of the parts that I think is a next step to make sure that programs like yours endure is the comment that Ellie made about each $1 we spend here generates X number of dollars. And these programs are not going to have the infrastructure, I would think, to create that kind of a business plan that we can then sell to the folks who control the revenue stream. But we need to start looking at what each of our processes, what does the medical home create, and how much does it save in downstream healthcare, and how much investment does it take to create that long-term return?
Can you all say a little bit more about how you generate that evidence?
Well, for Nurse Family Partnership, it was a RAND evaluation, and people love to evaluate this program because it's so long and it's got so much evidence. The other thing that's important with that is bipartisan support has helped us go a long way.
So the Health Collaborative in Cincinnati now has claims data from 5 different payers. 2 of those have given us cost data. The case is to make a return on investment reason for patient-centered medical home, to be able to show ED visits and utilization and all of those things too. But I think some of our other speakers spoke to the fear around disclosure of market share and allowable costs, and we're really struggling with that. We have very, very thoughtful business agreements with our payers around this claims day, and it's a trust walk right now. We are being very careful on who we can release that data to. We'd like eventually to release it to the consumer. It's their data. And to your point, the payers know. They know that PCMH and these other models give them a return on investment. And so we've had Humana actually step up and say that any practice in Cincinnati that's a NCQA recognized PCMH will continue to give a per member per month incentive. They were part of our pilot, and they've stepped out and said, we have enough data right now to go on, and so we're going to continue this. United and Anthem are saying that we like the pilots that you started in Cincinnati. We're still a bit reluctant to spread this, but they have their own data too. It will really make the case when we have aggregate data. Medicaid and CMS and others have spoken to that as well.
Access to the data isn't the only problem. Actually proving whether projects with high-cost patients or any bucket of cost saves money is really challenging. So there's, as many of you probably already know, there's something called regression of the mean. So if you take any high-cost thing, in fact, if you take any variable that's an outlier and just watch it, it tends to regress to the mean. So if you do nothing to a Camden high utilizer, statistically they will regress by 1/3 to 1/2 in their cost. So that makes it really challenging. And plus, when you're dealing with outliers, who do you match them to? So you can do a randomized controlled trial, but each of these patients are so extreme that if you throw one into one group or the other, it can throw things off. The other way to do it is something called propensity scoring, which is you use historic data to find matches. So we have all the data, we can do propensity scoring, but it can have pretty substantial confidence intervals of statistical significance. Then the third way is sort of this actuarial smoothing. It's sort of looking at big enough numbers. But once you get to that big, you've kind of smoothed all the data out, and it's hard to look at individual variations. So our science, I think, needs to advance on this, and we're part of a grant with the Rutgers State Center for Health Policy to help us use our data to kind of figure this out. We just hired a PhD inside of our organization to figure this out, but it's really hard. So even once you get the data, going the next step, as CMS is finding out, the 5,000 number they set for Medicare, has a pretty huge confidence interval about, ensuring that you didn't just have noise showing you saved money or cost money, but, getting to a real number. So I think we're just at the beginning of this, and I'm not an expert in it. I only know enough to know that we don't know yet what we're doing.
Other comments or questions? Yeah.
Hi, I'm Dr. Caroline Poplin. I'm an internist, a board-certified internist, and not a leader. I'm a worker bee. I spent 15 years seeing patients. And one of the things that's distressing when you talk about lack of empathy with patients is that primary care providers are under a lot of pressure. We have to meet performance requirements. We have to meet productivity requirements. And nobody ever asks us what we think the problem is and what we would like to see to fix it. They just propose a solution that, it sounds pretty good, and it works at Geisinger and it works at Kaiser. The people making these decisions generally don't see patients at all, or they're in very protected academic practices where they do some turns on the floor and they do a couple of resident clinics, and that's what they think practice looks like. I'm surprised that you didn't know that your diabetics weren't doing well. I knew how my diabetics were doing, who was doing well, and who wasn't doing well, and why. And
so is the question, is there how to get more reforms driven by clinicians in actual practice? Or?
You're talking about leadership, and I think one of the attributes of leadership should be talking to the people who actually do the work.
Yeah, and let's say I worked and still do see patients, but also was at Lincoln Heights Health Center, first FQHC to be NCQA recognized, but we have no EMR. So my comment was really, I didn't know how my patients were doing in a population. And population health isn't something that we teach our med students either. I knew who came to see me, I knew when they came to see me, but I didn't know overall how my patients were doing as a group. And I want to also just make a plug for Lincoln Heights too. The medical director of Lincoln Heights, Bernie Lenschitz, is really a physician's champion around this transparency. He's the first one at our medical meetings to offer to show his specific data. Because he'll say it, overall, his data's the worst. And so by stepping up and saying, look at my dashboard, he creates atmosphere for the other docs to feel comfortable around this transparency. I agree. We need street credibility, and we have to have physicians who are seeing patients to be part of the solution.
I agree 100% with you. We need more frontline providers. Up till 2 years ago, I was a frontline provider and had to make a choice. And I think most of my comments were directed at really needing to flip the power hierarchy in medicine and the need to take more frontline providers and elevate them up into CMO and CEO and higher level positions, because the people getting up to those jobs right now are not primary care providers. They don't have a holistic view, and it's not clear what their purpose is to get into those jobs, whether it's to make more income, whether it's to serve a community purpose, to be a servant leader, or to serve their own needs. So I agree 100%.
I agree with you, and I want to add to that if you don't mind. We have to hear from the patient, the client, the consumer, the customer, whatever in your world of healthcare you call this person. They're who we're trying to serve. And where is their voice? So I just want to add that to it.
And any final thoughts on how to do that? I mean, one of the things that's striking about these community-based initiatives is that they do try to put patients front and center and outcomes that matter to patients, like how well a family is doing or whether people are actually able to go on and live their lives, often in very difficult environments. Put that front and center. And I think that's one of the things that has driven a lot of your work out of kind of traditional ways of delivering care. Are there any further lessons on how to promote that perspective effectively in emerging healthcare organizations and as part of this healthcare reform effort?
Yeah, I think that we're recognizing how powerful consumer engagement truly is, and how we as physicians can help patients become more activated. We all want to work with an empowered patient. That's the dream. And so there are lots of tools out there that we as physicians can help to direct our patients to around that. We also need to make them part of the leadership, and there's challenges around consumer engagement, but I know that there are very progressive, Robert Wood Johnson is recognizing this, aligning forces for quality and making consumers part of the solution, activating them so that they can be effective in these meetings. You can't just have somebody come off the street and tell their story, but they need to be part of this discussion.
There's failed ways to do it that are very interesting. If anyone knows about the Federally Qualified Health Centers governance model, they have 51% consumers, and I've worked in an FQHC. Some of you may be familiar. It works rarely. Most of the time it doesn't work because in a poor community, it's not necessarily the 51% consumers on the board aren't necessarily people who can sit on boards and hold the board leadership accountable. They're sort of handpicked. So we have a lot of phony models of patient leadership, at least in poor, underserved communities, where people are plucked out and put in positions where they're not really being leaders. So in our organization, the 2 seats, they are CCOP members. So Camden Churches Organized for People has 2 seats that are for community members, but the staff from CCOP come to all the meetings, and they meet beforehand with the residents. They meet afterwards to debrief. I will go and sit down with them sometimes, and now they ask really hard questions because we've taught them claims data, they know how doctors get paid, they know about the whole deal. So I think patient engagement is telling the truth, and the truth is telling people why the doctor's running for the door handle in 10 minutes, why they got thrown out of the hospital, why no one translated, why 12,000 people in Camden went to the ER for head colds and the ER's tripled in size. Like, we need to pull aside and explain the money and the power. So engagement isn't just a patient being health literate in a room. It's being able to stand on the balcony and get what's really going on.
Every one of us in this room touches a patient or client, whatever we want to call them. So if we just listen for the intent of hearing what they have to say and hear it with respect, I think we can represent patients too.
I'd like to thank our panel for an excellent discussion. Thank you all very much.